Thank you very much, chairpersons. As the chairperson was mentioning, the title is a little confusing. It just reminds you of the Good Friday, which just was a couple of days back. Uh, Resurrection is also a word which is used for the Judgment Day. So I think I will keep that in mind and probably take this. Now, just look at these landmark studies wherein the sulfonylureas have actually been a very integral part. Show me one study where the competitors to sulfonylureas have a name to talk about like what sulfonylurea can talk about. Wikipedia's Descartes Advanced Adopt VADT Navigator, and it's been the active comparator for non-inferiority trials, a number of them. So it really is not the resurrection. So let's see another thing about sulfonylureas. Now, who can replace the sulfonylureas? I'm not going to be talking ill of any other drug. I may use the word DPP-4. I respect DPP-4s a lot. But then look at the basic difference between a sulfonylurea and a DPP-4. Sulfonylurea just needs to have beta cells intact for sulfonylureas to work. Now, if you look at a DPP-4, it's a drug with multiple hurdles. You have to have the beta cells intact and you have to have a GLP-1 intact. So unless both these are intact, a DPP-4 cannot really work. But then when it comes to sulfonylurea, you just need beta cells. As long as there is beta cells, sulfonylureas work. So in a way, sulfonylurea is a much, much better drug. Let's take a walk in the market to see whether sulfonylureas really have to be brought back from the dead. No, I don't think so. If you look at the market today, it's a 2,200 crore market as far as India is concerned. It's huge. Now, if you look at the DPP-4 market, it's about 1,324. Now, the point I want to make here is, in an industry where there is a lot of competition, obviously, a fantastic apple like a sulfonylurea, the others also would like to take a bite from this beautiful apple. Now here, the size of the bite, as you can see, is close to 2,200 crores. So you look at the DPP-4 market. I mean, this is a great molecule. I'm not talking against this molecule at all. I mean, there are a number of players who are fighting for this. Now, whenever there is a new product coming into the market, there are people with MBA qualification. Now, they are actually called the men behind the accounts or men behind advertising. Now, you need to push your new molecules so hard that you need to actually outscore the older ones. So when you need to push them, you look at small little defects that you can pick off a great molecule. You need to highlight that small little defect, blow it up in 70 mm and HD, and then tell the doctors, look, this particular problem can be very, very detrimental. My product is much better. And that's exactly what's happened to sulfonylureas. A great molecule which probably kind of got a feeling of a stepmotherly feeling because of an unfair comparison. And unfair comparison has always been on three things: weight gain, hypoglycemia, CV risk. Weight gain, hypoglycemia, CV risk. Every time you go for the last 5 years, you have been talking only about this. Oh, your sulfonylurea causes weight gain. Oh, your sulfonylurea causes hypoglycemia. Your sulfonylurea is not good to the heart. So repeatedly, if the same thing is told to the doctors, at one time we start believing, oh, maybe it is true. Because every single speaker is been talking about the same thing. Your own seniors, your own senior colleagues, your own teachers start talking about this. Now, my job today is not to look down upon other molecules. My job today is to show you people what is the evidence we have with sulfonylureas. Now, how does it compare when somebody blames weight gain, cardiovascular risk? let's start with the efficacy. Straight away, let's start with the efficacy. Look at only the first two columns. I'm going to hide this column. As far as efficacy is concerned, it's miles ahead of its competitors. It's a Muhammad Ali. There's no doubt about it. You need metformin at all times for a DPP-4 or the newer molecules which are going to come to work. But sulfonylurea as a monotherapy is a fantastic drug. So efficacy-wise, absolutely there is no problem. Now, what is the first charge? Moment you tell the competitors of sulfonylurea that, look, this drug is far superior in terms of efficacy, the first charge that they're going to talk about is, oh, because of its fantastic efficacy, there is going to be beta cell exhaustion and there is going to be apoptosis. So you're going to lose all your beta cells. So don't use the sulfonylurea. Now, is there any truth in this particular thing? Now, let's look at it. Now, they also go on and tell us, look, maybe DPP-4 or maybe the newer SGLT2 will preserve the beta cells. They also sometimes put up the photograph of one of my friends, Franco Foley, and says, okay, this is the work he has done and this is what it is. But what is not told to us is, there's only been 1 or 2 studies in animal models where you have actually seen the beta cell preservation, and that too, these rats were younger rats. When they tried to do the same experiments in older rats, there was no beta cell preservation. And for the last 10 years, exactly the same slide is being used by all the doctors worldwide. Now, what is the truth behind apoptosis? Very simple. Evidence from Wikipedias. There is no beta cell exhaustion or apoptosis at all. So tomorrow in your clinics, if somebody talks about too much of efficacy of sulfonylurea leading to beta cell exhaustion, apoptosis, please use this slide and say, look, it does not cause, because Wikipedia is something that we all believe. Now, the moment we started speaking about no apoptosis, in terms of efficacy, the DPP-4s and probably the SGLT2s started showing non-inferiority trials. They said, okay, fine, in that case, we are as good as sulfonylureas in efficacy when we come on with metformin. So they never said we are better. They said, okay, we are non-inferior to sulfonylurea. So what do we have to say for this? Now, look at this effectiveness and safety of glimepiride with the DPP-4 when you actually tag it on with metformin. There is very, very clear evidence that glimepiride with metformin is a much, much better in terms of efficacy compared to a DPP-4 with metformin. There's no doubt about this. We have evidence now to say. Having spoken of efficacy, let's move on to weight gain and see what is the truth behind this weight gain. The moment there is going to be weight gain, there are 101 things spoken about it. Now, if you actually go through a lot of evidence, all that you see is at the end of a 3-year, 4-year, 5-year trial, the weight gain is a maximum of 2 kgs. It ranges from 500 grams to 2 kgs. And that's about the weight that all of us are going to gain at the end of this Diabetes India conference, because we are going to be eating so much of food. And just a little readjustment in terms of diet, the weight is going to be neutral. I don't think this is a major problem at all, because of its good efficacy, there's going to be a little more insulin production when we use glimepiride or other sulfonylureas. Obviously, it's an analog. I mean, anabolic action of insulin will probably give rise to a little bit of weight, but otherwise there is absolutely no problem. Now look at the advanced trial, which used a different sulfonylurea. Weight change, 0. Absolutely no problem. Now you look at the meta-analysis of DPP-4s. They themselves claim that we are weight neutral. They never say we reduce weight. SGLT2 will now claim that it reduces weight because there is data now. With DPP-4, it's weight neutral. Now, the next bug that we have to cross is hypoglycemia. Is it really that bad? They just don't talk about hypoglycemia. Whenever we say that, okay, hypo is fine, I can always talk to my patient, they can take some glucose and things are going to be okay, it doesn't stop there. Now, in terms of data, there's going to be a lot of slides which will talk about how hypo leads to endothelial dysfunction, and that leads to atherosclerosis and higher CV deaths, etc. Now look at this slide. Anybody taking insulin? 51%. Oral agents, 27%. Overall, all the patients, 37%. So at some time or the other, people are facing hypoglycemia. But when insulin is used, nobody talks of hypoglycemia. It's only when we are using the oral tablets. The focus of advertisement is on hypoglycemia. Now, why no one speaks of hypoglycemia as a side effect when insulin is started? We know. There's no way you can manage a diabetic patient on insulin without hypoglycemia. Then why blame only sulfonylureas? Hypo is never a side effect as it's made out to be. It's the effect of good efficacy. So you just need to educate your patients the way we educate them when we start them on insulin. So hypoglycemia is something that we need not have to worry. Now, I have been an author of this particular paper where even DPP-4 clearly showed that it causes hypoglycemia. When we switched patients during Ramzan from sulfonylurea metformin to a DPP-4 metformin, there was a reduction of 50%, but it did not go. So now most of them say yes, there is going to be some hypoglycemia. So hypo is too much of the effect. It's not a side effect. We need to educate the patients about it, but it's not a very major thing. Now, if you look at hypoglycemia in the same study with glimepiride and metformin, it's very clear. 9.1 metformin with DPP-4 versus 11.2 when glimepiride and metformin was used. Is hardly 2% increased risk of hypoglycemia is actually nothing. But if you look at advance, 0.7% was a severe hypoglycemia where sulfonylurea was used. So hypo is a problem. It exists. We have to recognize this. We have to educate the patient. But that should not be the reason for us not writing a prescription of a sulfonylurea. Now, when it comes to CV deaths, invariably these slides are shown. See, all sulfonylureas causes cardiac events. Now, look at the cardiovascular events and mortality. Now, this is a trial where metformin and insulin was used, and metformin and sulfonylurea was used. It was glimepiride. Obviously, if you look at the cardiovascular disease or death, or if you look at the fatal and non-fatal cardiovascular events, actually, the metformin sulfonylurea group did better than the metformin insulin group. Now, can we stop using insulin just because the data says that there is a slight increased risk? No, we don't do that. So, similarly, whenever a data is shown about cardiovascular risk, we need to be extremely careful. So, sulfonylureas are safe CV safe when it comes to diabetes treatment. I don't think there is any doubt about it now. Now, coming to the CV, this is how I should conclude. Saxagliptin, the SAVOR-TIMI trial also said there is neither reduction nor increase in the composite endpoint. Now, I myself wrote an editorial on CMRO. This is about 2 years back. With the findings of the SAVOR-TIMI 53 showing increased hospitalization with heart failure, the last word is still not out. However, it is clear that most had high pro-BNP levels at the start of a clinical trial, indicating probability of a high risk. So, with other trial results just around the corner, DPP-4 may probably clear the cardiac safety, but we'll have to wait and see. So, it's still not out of the cloud. Do sulfonylurea still have a role in type 2 diabetes? Yes. And this is from the 2011. Sulfonylureas represent a very well-established flexible class of glucose-lowering drugs. And this is a list of what is an optimal drug for type 2 diabetes. Today we know what the ADA says. It's going to be patient-centric approach. I leave you with this particular slides which says a good physician treats the disease, a great physician treats the patient who has the disease. 55 years of sulfonylureas, absolutely still going strong. Just read the one in yellow line. Newer therapies are unlikely to have either a cost or a safety profile so superior that sulfonylureas will be relegated to history. And I'm sure sulfonylureas will run for many, many more decades. Especially in a country like India, we need to remember about 70% of our people are still in the rural. So cost is a major problem. I didn't even want to talk about the cost. So we have to make a conscious decision as far as the cost is concerned. Yes, there are some advantages of using other drugs, but can my patient afford the drug? So this conscious decision has to come from us as doctors. Thank you very much. You make the decision. I will not tell you what you need to write, but you make the decision. Thank you very much.